Okay, can you see that screen yet? You can see my screen? Okay, good. All right, excellent. All right. Okay. All right, this is a really little bit different. I want to just make sure that you can hear when the sound comes in later on today. I want to make sure that you'll be able to hear me. So let's talk about safe medication use. And if you can see that slide presentation, that's wonderful. A couple of things that I just want you to be aware of. There's something called the Beers criteria. And I know that quite a bit of this was presented by your peers in their presentation. Beers criteria, we'll talk a little bit more about that in just a few minutes, but it is a list of medications that are considered to be high risk for our geriatric patient. And so that's why they call it Beers criteria. It was designed by a person by the name of Beer. I'm sure you are familiar with pharmacokinetics, pharmacodynamics. I'm not going to go into that information. And of course, we've heard us talk a lot about polypharmacy. So we also are very much aware that medications are an important action by nurses. However, we know that for the older population, that these medications can act differently in older adults. So what we're going to do is we're going to go through each one of the classifications and point out some of those most important things. A lot of important things I have underlined or I have colored in red just for you. All right. Again, always remember that there are aging changes. We won't go over all the different aging changes. However, I will mention to you this afternoon or later on when we are going through our review that Chapter 5 in your gerontology book is a quick overview of all the different changes that occur in the older population. Please be sure you are well aware of the physiology and the changes, because not only for your exam, but also because you'll be answering questions on the NCLEX and the ATI, perhaps for some geriatric patients. And when you're caring for those, obviously you would want to know that. So please be sure you just kind of briefly glance through that chapter as well. Lots of different effects on aging. All right, so polypharmacy, as you know, there are many patients, are older adults that take more than one drug. You're very aware of that. You've been out in clinical. You've seen maybe 10, 20, 15, maybe even more of medications, because we know that one medication can cause a side effect. And so they give them something else to manage that side effect. And then the next thing you know, they're up to a huge number of drugs. And the problem with that is that there's so many drug-drug interactions. Every time you have a side effect or an adverse reaction, we have to do something about it. So polypharmacy is really bad, okay? As far as the pharmacokinetics, we do know that in the older population, rectal is not absorbed as efficiently. We know that PO is usually the best that we can do for our patients, and it's better to do that. We know that circulation changes in our patients. The cardio system, GI motility will drop down, will slow down a bit. We also know that there's a decrease in hydrochloric acid. So all of those things are going to affect how the patient absorbs and manages that medication. We also know that for our patients, that anesthesia, if they have to go to surgery, that their heart tissue is much more sensitive to the anesthesia. We know that the central nervous system becomes much more sensitive to alcohol and opioids. So just keep these things in mind as you are caring for your older adults. One of the things here that's important is mental dysfunction is really an early sign of many adverse reactions to medication. So if your patient has been on take some medication and there's something going on with mentally when you're doing your level of conscious or your checks for that patient, their orientation status, think about, did they just receive a new medication, or have they been taking one medication so long that now those adverse reactions are beginning to be a problem for them? So mental dysfunction is truly often an early sign. This little discussion here came from Geriatric Nursing Journal. And if you want the journal information, I can always send that to you. However, I think this was important to remember as we go out there and become nurses and start working with our patients and transferring those patients from an acute care setting perhaps to a long-term care facility. We do know that changing from one place to another really can cause a lot more problems for our older adults because they have so many health problems. There are many common medication discrepancies from the hospital to the home transition, as you can see here on the slide. Notice this, discrepancies of medication with 94% of the participants having at least one discrepancy. That's a huge number. This was a study conducted by the authors. The average medication discrepancies, of course, was 3.3 per participant, and all classes of medication were involved, even those with high safety risk. We must be able to really do a really good medication reconciliation. If you're bringing that patient into the acute care center from home, we must do that medication reconciliation. If you're sending that patient from the hospital, say to a nursing home or even to a home, we must do the same thing, because there has been shown that there is an increase in discrepancies in medication. I know that I have had multiple patients that have come into the hospital and they're not getting all the medications that they took at home. I had one that was on Lasix, furosemide, and they asked me about it, this gentleman, and he was an older gentleman. He said, what about that water pill? There was no water pill ordered for this patient at all, no furosemide. And he was a little swollen. His ankles were a little swollen. So I contacted the healthcare provider. They weren't even aware that he was even on that medication, but they put him on it because he needed it. However, also because our patients go from one doctor to another, different specialties, we know that there's many things that go on in one doctor's office compared to another doctor's office. And some of that information does not always transfer over to each doctor. So again, just kind of keep that in mind. On page 231 of your textbook, as I mentioned, is the beer. It's a box 17-1. You might be able to see it. I don't think you can see it because my camera's not working when I'm doing PowerPoint. So anyway, 231. I'm not going to ask you a lot of questions on here. I'll tell you which ones I want you to know. However, we do know that these are some of the drugs that really carry a really high risk for our patients. And so we don't really want them to take these meds. Sometimes the doctors will still order those medications. Even the antiarrhythmic drugs, they have some really adverse reactions to the older adult. But what do? What is the healthcare provider going to do? They may have to give those medications anyway. So just glance through that. You're going to see a whole lot of medications that the older adult really shouldn't be using. However, it is truly up to the healthcare provider as to what they want to order for that patient. So if we know something about the Beers criteria, and you have a patient that's taking a particular medication that really they shouldn't be on, such as an antipsychotic, then you need to remember that there are some serious adverse reactions that could potentially occur with that patient. So here's a little bit more on Beers criteria. Basically, when patient is taking the stimulants and the tricyclics, the TCAs, we really don't like to give those to our older adults. Anticholinergic dries them all out. Muscle relaxants, antidepressants, and decongestants. all of these things can cause, as you can see on the left-hand side, arrhythmias, bladder flow obstruction. I mean, all kinds of things. And of course, if they're on aspirin or NSAIDs, Plavix, which is clopidogrel, well, then obviously there can be some high adverse effects with anticoagulation. It could happen also in younger people or younger adults. However, it's much more prominent in the older population. So just kind of remember, this is important. Be sure you know the scope of drug use and significant adverse reactions. And so when you are looking at a patient's drugs, you want to ask yourself these questions. Why is the drug ordered? Is it the smallest possible? Remember, generally speaking, the older adults should have a low dose and go slow. If they have to up that dose, it needs to start slow and low and go slow. Okay, so is this all they need? Not that you're going to question the doctor, but you can certainly be aware of it. And if you do have a concern or an issue, you will talk to your healthcare provider. The allergic reactions to the drug. What about the interactions with all these other things? Foods, drugs, herbs, all the interactions that you might know about your particular drug. Are there any special instructions about giving the drug? If there's no special instructions and you think there should be, again, that's something to think about. But you must be able to review the drugs and to ask yourself these questions. And of course, is the most effective route of administration being used? Sometimes they will give a patient a rectal when you know that rectal medications is not the best for the older adult. So maybe there's a way they could do a PO. So anyway, ask yourself these questions when you are doing your medication reconciliation or just looking at your list of drugs for your older adult. Important. As I mentioned earlier, the common route, most common is really the oral, but there's all kinds of things that can influence that. In the suppository, because of the low body temperature, it takes a little bit longer. So if we give a patient acetaminophen rectally, then it's going to take a little bit longer for the medication to dissolve and go into the bloodstream, which is something that we need to be aware of. And of course, anytime we give IV IMs of any form, really, it could be a problem because of the subcutaneous fat. Number one, subcutaneous fat on the older adult is much less, so we have to make sure we're in the sub-Q and not in the muscle when we're giving our medications. All right. If you're giving medications or an injection in an arm, and that arm can't move, the absorption is going to be a lot less and a lot more, much more slower. So keep that in mind as you are determining where you're going to give your injections. And of course, IV, you already well know that overload is the issue for our patients with IVs, and we just have to watch that with our patients. Of course, we always do patient teaching, okay? And as you have studied about teaching our patients the cognitive, the psychomotor, and the affective domains. But always remember that we have to make sure the patient is able to understand what you're trying to teach them. If they have to give injections, they have to be able to functionally do it. Can they open their own pill bottles? Can they do all of those things? Can they hear you? Can they see you? All right. Lots of factors that interfere with that. Keep in mind that a lot of medications have to have some blood work of some form. So remember if that's one of your medications, don't forget that you have to look at those blood levels. For instance, remember the Lovenox, enoxaparin, needs to be looking at the platelets. Again, be sure you are familiar with what labs that you need to be looking at. Potassium is also another lab value that we'll look at for many of our drugs. All right, some other alternatives. Just remember that the way the healthcare provider determines whether to give them the drugs is really the benefits versus the risk. There's always risk with medications. In fact, every medication that you have studied has some type of risk, regardless of whether they're old patients or whether they're young patients. But the healthcare provider is aware, and so sometimes they still have to give it, even though they can be harmed by the adverse reactions. So let's look at some selected drugs here. The first one are analgesics. Two very important ones to be familiar with is aspirin. You know that it causes gastric bleeding, of course. And acetaminophen does not have any anti-inflammatory ability, so it's really not good for arthritis. Right? Acetaminophen is not for the inflammatory process. We tend to use bone and muscle. We tend to use ibuprofen for that. However, just some little things to think about, right? And remember that also that we have to be sure that we are teaching our patients about how to use these medications. So let's talk about some of the guidelines of what we might teach. Of course, with analgesics, you always look at the pain. If there's something else that we could do as a nurse, non-pharmacological, that would be awesome, because that's what we want to try to do. Try to do something that's non-pharmacological to help relieve some of that discomfort and pain. And again, weakest amount and the smallest amount of dose, and gradually increase it as needed for our older patients. Remember, their liver doesn't function very well as it used to, and they cannot metabolize those drugs like they used to, okay? We also know that for analgesics, we need to maintain that blood level. And so that means we want to be sure that we are administering those as if it's around the clock medication, making sure that we have enough of that medication in the patient, all right? The other thing is that if a patient is taking aspirin or acetaminophen, it can actually mask an infection because of the fever. So if they don't have a fever, that doesn't necessarily mean that they're not having an infection. So be sure that you're looking for signs and symptoms of any other type of infection. If it's a wound, keep a look at your wound, assess that wound, the redness, the edema, any kind of discharge from the wound, because when we take aspirin and acetaminophen, it's going to drop that fever down, and or drop it so far that we don't think they have a fever. Okay, so be sure you are checking for signs of infection. As we mentioned, long-term aspirin use because of the bleeding, and it can also delay the patient's clotting time, which is important to remember. So as always, we're going to be looking for signs and symptoms of bleeding, anemia. We do see a lot of rectal bleeding on our patients, particularly those who take analgesics. All right, so watch that. Salicylic toxicity, you remember for aspirin, you need to know the signs and symptoms of that, which is dizziness, fever and vomiting, and ringing in the ears or tinnitus, burning in the mouth and throat is salicylic toxicity, and even coma. So if your patient has been taking a lot of aspirin and they come in with some of these signs and symptoms, you can obviously think, well, maybe they're too toxic, because the bloodstream is not, the liver is not able to metabolize enough, and so what happens? The toxic effects of the aspirin will go up because the liver is not functioning the way it should. So if you have aspirin with a sulfonylurea, we want to be sure that we're watching for a hypoglycemic reaction. And again, some other things too is that because of the liver damage, we know that signs of poisoning, let's say maybe they had an overdose of something, may not show up for a while because of the liver damage. And so it's important to be aware of what's going on with your patient. Make sure you get a good history as well. All right, so that's all on analgesics. Let's talk about antacids. We got to know, why is a patient taking an antacid? There must be a reason. And really, if it's chronically they're taking an antacid all the time, then usually the healthcare provider needs to be notified, because why are they taking it? And it could be something that can be treated. If it's GERD or whatever it might be, it can possibly be treated. So if your patient comes in and says they're taking a lot of antacids, well, that's something to think about. Okay. However, for antacids, the patient should only really take them when they're needed. All right. So let's talk about some nursing guidelines for antacids. And I think sometimes we forget to ask them about taking antacids, because it's such a common thing. You buy them over the counter. I think there's 15, 20 versions of antacids out there. But again, when you are doing your over-the-counter medication interview with your patient, or what kind of meds they're on, what do they take at home, what do they go to the Walmart and get, it's important to ask about antacids. Just a reminder, that antacid should not be administered close to other medications. All right, so important to remember that. And because the antacid can kind of slow down the absorption of the actual medication. So that's why. There are some problems with antacids. If they use aluminum hydroxide or calcium antacids such as Tums, it can have constipation. Diarrhea can come from magnesium hydroxide. And of course, they can have both of those. If they take a lot of antacids, they can have some real serious issues between constipation and diarrhea. Then when you're looking at diarrhea, you're thinking about, okay, what is the hydration status? What should we do? Are we doing a skin turgor test? Are they dehydrated? Look for signs and symptoms of dehydration if they tell you that they're having a lot of diarrhea. Okay, constipation, that's important to take care of, simply because of the fact that those patients can become impacted, and of course that could be an issue. For those who are on sodium restricted diets, we want to make sure that they don't take sodium bicarb as an antacid. You've heard of sodium bicarb baking soda in the cupboard for cooking. For many older adults, all their life they've used baking soda to help with their indigestion. Well, one of the problems with that is it's a bicarbonate. And of course, it can get us into a metabolic alkalotic state if they take too much. But also, the sodium in it can cause a problem if they're already on a restricted diet. All right. That's antacids. Let's talk about antibiotics. You know that the more we take in antibiotics, the greater chance and risk of developing colitis of some form, antibiotic-resistant medications as well. Antibiotics are great, but they also destroy the good things in the gut, in the human gut, and sometimes it can lead to C. diff or some other type of intestinal problem. So we try not to overdo the antibiotic if we can help it, right? So be sure you are familiar with your different drugs. I'm not going to ask you specific drugs on these. I would have put them on there if I was going to, but just know your group, your classifications. Also, do remember that if you are going to give an antibiotic for the first time and the doctor has ordered a culture, again, make sure that you are doing the culture before you give that antibiotic. Again, just like many medications, we have to keep it on a level over a 24-hour period. We don't want the level to drop. And so we want to make sure that there's a regular schedule, and the patient needs to be taught that. They may not realize that it should be every 6 hours. Maybe the doctor says, "I'll take it 4 times a day." Well, that's, to a patient, that doesn't necessarily mean every 6 hours, the way you would know it to be done. So that's something that has to be taught to many of our older patients and their families. Don't skip the doses, of course, and be sure that they take all the medications for the exact amount. So some of the medications will say take 10 days, some 7 days, and that they wait, if they only go for like 3 or 4 days and they're feeling better, many times they'll quit taking it and put it in the medicine chest or the cupboard and say, oh, I'll need it next time. But as you know from your pharmacology studies, how that could affect that infection. In fact, the infection can come back simply because it has not been completely killed, because these organisms colonize and are not completely destroyed. Right? So be sure you're watching for signs of the super infections, which are very difficult to treat. So which class of antibiotics requires monitoring for hearing loss and renal failure? Is it the aminoglycosides, the penicillins, the fluoroquinolones, or the cephalosporins? What do you think?
I think it's A.
Mm-hmm. Yes, it is A, aminoglycosides. Yes, absolutely. Notice that penicillins and cephalosporins, they are, even though they're different categories, they're actually the allergic reaction between the two of those. If somebody is allergic to penicillin, we don't really want to give them cephalosporins because there's always that potential for a reaction, right? So definitely aminoglycosides. All right, so for your anticoagulants, we have to know why they're taking an anticoagulant, okay? Is it because they have AFib and they have to be on Eliquis? Are they taking warfarin, Coumadin? What is the purpose? Why are they taking the anticoagulant? It's important that we know that. There is extreme high risk for bleeding, particularly with our older patients, particularly if they try to take NSAIDs or aspirin at the same time that they're taking an anticoagulant, and it could only exaggerate the bleeding potential. So always remember that. So heparin is also another one, anticoagulant, right? So let's look at some nursing guidelines. Most of the time, the anticoagulants, we do a PT and a PTT. And the INR, of course, is something that we have to be sure we're paying attention to. For Coumadin, warfarin, yes, we're going to do a PT, PTT for that. For Eliquis, there's really nothing that they have to do because it's an anticoagulant, but there's no blood test required for that. So you don't have to take blood tests, but that older medication, definitely. All right. Again, just like with all medications, the same time each day is important because we want that blood level. And don't forget to teach them about bleeding. Bleeding can come from nosebleeds, epistasis. It could come in the GI tract. Yes, we do see that happening as well. So I've had patients on the units that have had come in with a GI bleed, and they've been on an anticoagulant, and they're also taking ibuprofen for arthritis. And so there's a great possibility and potential for those patients to have GI bleeds. So if a patient comes in to your facility with a GI bleed, you got to look and see, first of all, what medications are they on? Could it just be that's causing it? Could it be a cancer? Generally, it's something to do with medications, all right? Sometimes we do have the cancer piece, of course, as well. But teach your patients about the use of razors and sharp things that could cut them and those types of things. You're aware of those, okay? Don't forget about the vitamin K foods. Patients can eat vitamin K even on an anticoagulant. However, large amounts could be a little detrimental, okay, because it's for blood clotting. Vitamin K is needed for blood clotting. And if they're taking in a lot of asparagus, and you can see here cauliflower and green, we always think of dark green leafy vegetables, but there are other things such as cabbage and beef liver, of course, and some bacon. That vitamin K rich food can actually interfere with the actions of that anticoagulant. Mango and papaya can increase the INR So if your patient is one of those patients who likes their mangoes and papayas, and they're also on an anticoagulant, you want to take a look at that INR to see if it's unusual and find out. That's why food interview, the nutritional piece of talking with your patient, is important. So all of these things come together now that you are fixing to go out there and take care of all these patients and become a nurse. It's not just about the meds, it's about looking at their nutritional status, it looks about their age. So all of those things come together to help you provide the best care for your patient. Of course, vitamin E can actually increase the risk of bleeding as well. So just watch if they're on any type of supplements. Maybe they're saying they're taking a lot of vitamin E, all right, and they're having some bleeding. That could be the reason. May not be anything organic. It could just simply be meds. Okay. Okay, we do know that vitamin K is an antidote for anticoagulants, of course. By the way, what is for heparin? It's not necessarily anticoagulant, but heparin, what is the antidote for heparin?
Protamine sulfate.
Protamine sulfate. Yeah, that's very common. Yeah, very good. Okay, of course, we want to make sure that our patients who are on anticoagulants, they should not be taking aspirin because remember, aspirin interferes with the platelet aggregation, similar to Lovenox or noxiparin, and it can cause more bleeding. So if you find a patient who's on aspirin and they're on Coumadin, you might want to talk with a healthcare provider because it could simply be something else they could do. Maybe they're on a low dose aspirin because maybe a heart attack or something, and they're going to put them on a low dose aspirin. That still is enough to really potentially cause an increase in bleeding. So again, there's those benefits and risk that could possibly be a problem. So the doctor has to decide if it's more beneficial or there's more risk. So your teaching and understanding these things is so important. All right. How about those anticonvulsants? Well, there are some out there. Many of these are the treatment for seizures, and sometimes they give them anticonvulsants. Of course, there's blood levels to monitor. There's other medical uses for anticonvulsants. But the thing is, let's talk about what's important with those convulsants. I mean, what should we be looking for? All of these things that you see here on this slide are really some possible side effects. And boy, are they a lot of side effects. So if you have a patient on phenytoin or Dilantin or some other type of anticonvulsant, look at all the side effects. Yeah, blurred vision, double vision, slurred speech. I mean, it's like enormous amount of side effects for the medications that these patients are on. So I want to stress to you that if your patient is a polypharmaceutical patient and they're on anticonvulsants and other medications that can cause problems for them, sometimes they get more sick from the medications than they do from the good with the combined, the synergistic effect. So as nurses, we really need to be in tune to those medications and what's going on with our older patient. But look at that. It's like, wow. And of course, with all the bleeding and the dizziness of vomiting, not wanting to eat, they're now at a risk for falls. Okay. They might have been at risk for falls because of the seizures, but the anticonvulsants only can make it worse. Okay. All right. If there's any blood levels that need to be done, you will learn those, like phenobarbital, and of course Dilantin, phenytoin, valproic acid. All of those are anticonvulsants, and they need some blood levels. But they can also really mess up the kidney disease if they have it, or if they have liver disease. So just keep that in mind. But we should not be all of a sudden taking a patient off of anticonvulsants because it will do them significant harm. All right, so we're not going to do that. So let's teach them a little bit. Well, we've talked before about grapefruit and grapefruit juice. And honestly, grapefruit juice, just don't take it at all with medications. Even though there are some drugs that are much more sensitive to the grapefruit juice and the cytochrome, uh, I forget the number, P something of in the stomach. Actually, and what happens is that the liver cannot metabolize the particular medicine. In this case, it's anticonvulsants. And so there becomes a toxic level. And so it gets worse and worse and worse. So it's better not to really take any medications with grapefruit juice. And that's the reason you're not seeing it in the hospital. Okay. Anticonvulsants can really take a downward trend for patients who have glaucoma, CAD, or prostate disease. Can actually cause a little bit more problems or make it worse for the patient. And there are some that are photosensitivity. But again, I'm not going to ask you which ones, but just know that there's lots and lots of so many side effects that are related to the anticonvulsants. Now let's take a look at antihypertensive drugs. Well, diuretics, of course, are the most commonly used. All right. There's some beta blockers. There's some angiotensin converting enzyme inhibitors, calcium channel blockers, alpha blockers. There's all kinds of antihypertensive medications. However, the diuretics are the most commonly used to kind of help lower the blood pressure a little bit. So let's take a look at some of this. Anytime, class, a patient is on an antihypertensive medication, regardless of what category it's in, okay, please be sure you're doing those blood pressures very carefully. The book does recommend that we do the orthostatic hypotension checks, which is the lying, sitting, and standing positions. When you do have your patients go to those different positions, take them slow. Our older patients cannot adjust quickly enough, and so they might get dizzy. You don't want them to fall on you, all right, and wind up on the floor. So it's important to really assess their blood pressure very, very, very carefully. And don't forget, if you have a patient that has an unusual blood pressure in the arm, say the left arm, take it in the right and see if it's the same. And if you're not sure, do a manual. Because even the machines are not, we cannot rely on machines in our profession. It's good to have them and we need them, but if you're not comfortable with that unusual blood pressure, just take a manual one. All right, and there are ways to do that in the hospital. We still have manual cuffs and things available. All right. Okay, the other thing, we want to help our patients. What are some of the things that can help reduce their high blood pressure? Diet, of course, you're aware of that. Dieting, reducing some stress, if possible. Lots of ways that we can help them with the reducing their blood pressure if all possible. Weight loss is another one. It's a good one. So again, we want to monitor them very closely. And when you first give a patient an antihypertensive, they can actually develop a really, really low blood pressure initially. Like if a patient goes from one type of blood pressure to another, the body has to adjust to it, and so they have a higher chance of developing dizziness, syncope, and falling due to that hypotension. So it has to be adjusted. And sometimes you notice, I'm sure you have seen this in the profession so far, that sometimes doctors just have to, they give them a medication and see if it works. And if it doesn't work, they give them another medicine and we'll try that. And so it can be very difficult for our older patients, particularly, to have their medications changed and regulated because of the major effects of those particularly. Okay. And of course, if they are on a diuretic, that could cause that hypertension, their dehydration, actually hypotension. So be sure you're looking for signs and symptoms of dehydration on these patients at all times. Here's some other guidelines for you. monitoring that serum potassium, particularly with ACE inhibitors, with potassium or with potassium sparing diuretics. If they're potassium sparing, we want to make sure that the serum potassium level is not too low or too high, particularly too high, because if it's not getting rid of potassium, it's going to build up in the bloodstream. All right. Side effects are always something we're going to monitor, of course. And be sure that you develop a rapport with your patients and be able to talk with them and find out what's going on and if they're having any major issues with their antihypertensives. All right, hypertensives, or I should say antihypertensives. Well, let's talk about hypoglycemic drugs. Okay. There's always a potential for hypoglycemia. If somebody is taking an anti-diabetic drug, there's always a potential for that patient to develop hypoglycemia, okay? Because it might be a little bit too much drug. That's why with our older patients, we want to really be monitoring how much they're taking of the medication. So let's look at some nursing guidelines. Lots of information that we could teach a patient about diabetes. If they're a new diabetic, and it can be, type 2 is pretty common in the older adult population. It can be a new onset. Hypoglycemia, we want to make sure that we teach them as much as we can. If you are the diabetic educator, and by the way, that's a really good job these days. There's so many patients with diabetes. And if that's something that really interests you, you might want to check that out as a career move or a career path. However, you know, there's so much to teach them about diabetes. You can't just do it all in the hospital at one time. It's way too much. But hopefully you'll be able to give them enough information that they'll have handouts and support groups and regular visits to their doctor to help them deal with this condition. They have to know how to store the medication, you know, the insulin, or their regular drugs, of course. Okay. Be sure that they are aware that all insulins or oral anti-diabetic medications are not interchangeable. In other words, they can't just take somebody else's anti-diabetic pill because it may not even be the same pill, even though it does the same thing. Of course, you know from your pharmacokinetics, there's different processes in each of those medications. So we definitely don't want them to substitute medications for sure. Okay. Patients with diabetes should be wearing some type of medical alert bracelet. And the other thing with medications, if your patient is, say, taking an anticoagulant, it would be a good idea for them to have it somewhere in their wallet or their purse or in their cell phone where the emergency people can get to it. Because if somebody is injured in a horrendous car wreck and they don't realize that this patient is on an anticoagulant, this patient could bleed out really rapidly. So this is something we can teach our patients to have it available, have all your meds available, put a med list in your purse or in your wallet or in your car, wherever it needs to be, because the emergency people need to know if there's something really major here, okay, because they would be aware of it, okay, in much more detail. So again, identification would be a good thing. If your patients are going to be getting injections, of course you do all this teaching about how to give injections, but make sure that they rotate the sites so there's no development of any type of atrophy around the insulin sites. Usually it's in the abdomen that we see that. Could cause atrophy, and although it looks bad, it's harmless, but it's unattractive too when you see those little dips in their abdomen. So again, so much important things to teach your patients. All right. The other thing is, don't forget about the drug holidays, we call them. For instance, if the patient is has had some severe trauma, or they have a fever, or they've been throwing up, or their thyroid starts to act up, or any other type of major issues, they need to be sure that the healthcare provider is aware, because sometimes, as you well know, that we have to adjust insulin based on those things. If they exercise, we have to think about how should they adjust that insulin, because of the exercise is going to require more insulin. But again, they should be reporting all of this to their healthcare provider. Drinking alcohol, we just have to tell all of our patients basically don't drink alcohol, but particularly with these patients, because alcohol can cause a really deep drop in the blood sugar in the bloodstream. So we don't want that to happen to the patient. They'll become so hypoglycemic that they could go into a coma, okay, and die. All right, some NSAIDs. Well, it's a lot of categories of drugs, but everything we're talking about, class, you have studied each one of those categories. And so hopefully that this little bit of information kind of refreshes your mind about the broad pieces of the categories. I hope that's helping you. The textbook has got great information related to that. Okay. NSAIDs, we have to really talk to them about it. As we know that NSAIDs such as ibuprofen is good for bone and muscle pain. So let's take a look at some of those. There's a narrowed therapeutic window. In other words, too much of this particular medicine can actually become toxic to a patient. And of course, we need to lower those doses in the older adult. We want to look for any type of side effects. Again, we're aware of the GI symptoms. However, remember that with an NSAID, it could take several weeks before any bleeding potential, because it just takes a while to accumulate. And so they may not start bleeding right away. All right. So we just need to teach them about those GI problems. It could infect their hearing, of course, and some other things. However, these patients, our older patients, is a high rate of delirium. If they have a side effect from this particular drug, you can see older patients developing delirium, that they get confused. Remember, delirium is reversible if we can get rid of the medication, all right? Dementia is not reversible. So the older adults are at higher risk of developing that. So we need to be aware of that. If your patient comes in and they're on, I don't know, 800 milligrams 3 times a day of ibuprofen, and they've been on it for months and months and months, they may not have a bleeding problem, but they might be getting confused. And so the family is going to bring the patient in and say, there's something wrong. That it may not be a stroke, class. It could simply be a problem with the drugs. So don't forget that. All right. So, of course, blood evaluations as well. And anytime you take an anti-inflammatory medication, it's good to take it with food or milk, unless it's contraindicated, okay? All right. Again, I mentioned earlier, if a patient is on aspirin because of the cardiac issue, and they start an NSAID, well, that needs to be discussed with the physician and the pharmacist. All right, so it's important to remember that. And some other things, piroxicam and indomethacin is also an NSAID, but they can cause things like headache and dizziness and confusion. And again, some of that delirium we talked about. If the patient is on it for long periods of time, maybe there's something else that they can use instead of taking a chance of developing bleeding or some delirium. So keep in touch with your healthcare provider as you are beginning to practice. All right, so cholesterol-lowering drugs, we're seeing a lot more of that these days, and there's some here that I want to make sure that you remember, so I put them in red for you. The statins, usually we give that in the evening time because that's when cholesterol is created in the liver. We don't really need any extra cholesterol in our diet because the body makes plenty of it. So what happens is that like atorvastatin, Lipitor, actually stops the production of cholesterol in the liver. So that's why those are good. Of course, niacin is just another medication. It lowers the LDL and raises the happy ones, the HDL. And so that's sometimes they'll take niacin. They take some of these other things, bile acids and fibric acid derivatives and cholesterol absorption inhibitors. Statins here are probably the most common that we see. Okay, always remember that dietary and lifestyle modifications can be very beneficial in reducing the cholesterol levels. We know that oatmeal is great if the patient likes oatmeal. Many of our older adults like oatmeal. That helps to lower that cholesterol level. So dietary changes would be good. And of course, generally when somebody is on a statin drug, they will get liver function tests, once in a while, just to make sure that their liver is not being affected by this particular drug. Because remember, it works in the liver to decrease the production of cholesterol. So we want to make sure the liver is still functioning okay. All right. So cognitive enhancing medications like donepezil, which is Aricept, rivastigmine, which is Exelon, galantamine, which is Razidine. All of these medications, we use, particularly the Aricept for the dementias. And so it's called a cholinesterase inhibitor. And there's a few others, but there are side effects for these drugs, as you can see, headaches and dizziness, urinary problems, and there's a whole list in your textbook of side effects. There's tons of side effects in this particular medication. So what we need to do is just monitor this, evaluate how the patient is doing on this particular drug. And remember, what we're looking for, is it working for the patient? When you give a patient a drug, we always evaluate, is the drug doing what it's supposed to do? If not, what else can be done about it? Talk to the healthcare provider, the pharmacist. So that's really what we do. We want to make sure that it's doing its job, because why give a patient a drug if it's not doing what it's supposed to be doing? All right? Okay. A few more drugs. Digoxin is an important drug. It's very common. Okay. They don't use it as much. It's also Lanoxin. They don't use it as much, but we still see it in AFib and congestive heart failure and supraventricular tachycardia. Digoxin is definitely still used. Basically, it causes an increase in the force of contractions in the cardiac. And of course, it causes the myocardial to contract better, so the blood can go from, the ventricles out to the body through the great aorta there. So we do see it, and it's a very important drug to be able to remember. We got to be careful about the renal function with this patient, with this type of drug, because it can cause, because it's going to be excreted through the urinary system, and so if the renal function is not good, then it's going to be a toxic buildup. All right, and we'll talk about that in just a minute. All right. Need to always check for toxicity. All right. So basically, when you are giving digoxin, you should always do the pulse rate. Generally, it's below 60 that we're not going to give it. Generally, all right. You check the rate and right immediately before you administer the medication. However, we're also seeing that we do the blood pressure. Going to do a blood pressure anyway. So the best thing to do is be sure you're looking at that, because if the pulse is too low, that blood pressure could be dropping as well. Digitalis toxicity is something that NCLEX seems to like a lot, and so does many of the other exams that you might be taking. So be sure you know digitalis toxicity, and here are all the signs and symptoms for you. Of course, bradycardia. We look at hallucinations, lots of toxicity problems, cardiac arrhythmias. Okay, notice that toxicity can occur even if there's normal serum levels. for many reasons. Perhaps the renal function is not as good as it should be. So can't just go by high serum drug levels, okay, to develop toxicity. So digitalis toxicity needs to be reported immediately. Always check your potassium levels with DIG, okay? Hypokalemia makes a patient more susceptible to toxicity. So be sure that they are taking in potassium-rich foods, cantaloupe, tomatoes. We know about the bananas, lots of other foods, and that potassium is being checked pretty frequently and at irregular intervals to be sure they're not developing any type of decrease in potassium levels. Otherwise, the DIG is going to become toxic with them. Right? Just monitor for signs of those. There's a couple of classes of diuretics that your book likes to bring out. You have your thiazides, the loop diuretics, and potassium-sparing diuretics. I think the important thing here is to kind of understand why you're taking a diuretic, and what should we do about it? What should we monitor for? And one of the reasons we give the furosemide IV push when a patient, say, is in heart failure and they are having difficulty breathing and we can hear crackles in the lungs, is simply because it's very rapid acting and we can push that furosemide, and it goes quickly, and within less than 5 minutes the patient is voiding. All right. So loop diuretics are pretty common. Of course, because it's a diuretic, it's going to make people have to go to the bathroom. So we want to make sure we give it in the morning. Watch for the intake and output because of the potential for dehydration. And of course, look for fluid and electrolyte imbalances, such as, they get real thirsty and they get weak and they're all dried up, muscle cramps, reduced urinary output simply because they're becoming dehydrated. That's really what's happening, okay? And so we want to make sure we keep their hydration status at the forefronts of our mind when our patients are on diuretics, okay? A couple of other things to think about for diuretics is something called transient ototoxicity. And basically, if a patient is taking that loop diuretic, such as furosemide, we have to monitor the hearing. So that's a key. And the reason for that, if you have a patient who hasn't had a whole lot of problems with their hearing, and the doctor has ordered them to take some furosemide, and they've been on it for a while, and then they're starting to have hearing problems, it could possibly be related to the medication, right? Maybe not. Maybe they don't have a problem with their hearing, but now the medication is causing it. So that's something to remember. All right. Diuretics, of course, if there's a problem with liver or renal or gout. Now, the reason it worsens in gout is because, remember, gout is where the uric acid crystals, they accumulate in the joints. I've seen little gout on patients' ears. Little nodules on their ears. I've seen them in big toes. I'm sure you may have seen some of this as well out there in clinical. But because the diuretics are taking out the fluid, those crystals are not being flushed out of the body. And so they accumulate even faster inside the body and causes a lot of problems. All right. It could also raise that blood glucose level in the diabetics. It makes sense. They're taking out all the fluids, so your blood glucose is going to go up. So be sure you're looking at the electrolytes and BUNs, etc., for patients on diuretics. All right. We'll take a break when I finish this chapter. We've only got a few slides left, and that way you'll take a nice 15-minute break. So hang in there with me. This is just a review of things that you most likely know, which is good. All right. Okay, so laxatives. Of course, we really watch the laxatives in our older population, and there's different types of laxatives like bulk formers, like cellulose, the methyl cellulose, which is known as Metamucil. That's over the counter. Citracil, some of those as well that you can see over the counter. This is bulk formers, okay? You have some other types here, and then stimulants, of course, is your Ducalox, Cascara, and of course your mineral oil is a problem. Sometimes patients like to take, older patients particularly like to take mineral oil to help them have a bowel movement, but that mineral oil takes out a lot of the vitamins, and so they become, they vitamin depletion. So again, lots of different types of laxatives. It is a very common problem in the geriatric population. Many reasons why. Remember, the age changes in the GI tract, everything slows down. They don't drink as much as they should. They may not exercise as much as they should. And so the central nervous system, the ability to peristalsis is going to decrease at times. So there's a lot of problems with constipation, and maybe their diet is not high in fiber either. So be careful. Always remember, if the patient complains of that, we need to kind of assess that and maybe see if we can get them a laxative of some type. And again, be sure that we're doing teaching about the use of laxatives and how it can possibly interfere with medications. And that's something to always remember. Okay. Lots of fluid must go along with anytime you're taking that, like Metamucil, because what it does is causes like a jelly formation in the bowel, and it actually can cause bowel blockages if they don't get enough fluid in there. And even stool softeners, because what we don't want accumulation of stool in the bowel. Lots of good fluid intake for our patients. Some psychoactive drugs, I've got them listed all here for you. Antidepressants. So let's kind of look at some of these. We have our anxiety drugs. These are the benzos or the benzodiazepines, lorazepam. The PAM drugs are, that's basically how you can remember that if it's an anti-anxiety drug. There are some effects. Unfortunately, confusion, gait problems. If your patient is on lorazepam or diazepam, either one or any of those really, they're going to be a fall risk, okay, because they have trouble with their walking, their gait's unsteady. They can become confused. They can have seizures and hallucinations, all of these things. So take really care of those. So let's look at some guidelines in relationship to what we know about the anti-anxiety medications. One thing that, as always, we would prefer to do anything other than giving our patients drugs. But if there's something else that we could do, perhaps a non-pharmacological, it's always a good. And if you could think of something and suggest it before your patient goes on these medications, that would be great. And I will tell you, as you grow in nursing and you grow and you get to know the doctors that you work with, they will begin to trust you. And they really depend on the nurses to kind of keep them on top of what's going on with the patient, because we see them on a day-to-day basis. And we spend more time talking about their overall health than sometimes the healthcare providers have time for. So once you have decided and you got a job and you've settled down a little bit and got your license to practice, get to know your doctors, and you will see a huge difference in that communication between you and that healthcare provider. They will begin to trust you, all right, or they will trust you. Okay, so make sure we ask them to change positions slowly, okay, not to drive, if at all possible, simply because it causes some confusion and some hallucinations, okay. We want to make sure that they are eating some fiber, because it can cause constipation as well, right? And of course, just monitor their nutritional status and weight. Again, grapefruit juice is not something we want our patients on anti-anxiety medications to take, right? And of course, avoid alcohol and limit caffeine, right? Because, caffeine increases the anxiety, and of course, what alcohol does in the liver. So another group of drugs are the antidepressants. There's different types of antidepressants. The tricyclic antidepressants should be avoided at all times with these patients. Stay with the SSRIs. They're pretty well tolerated, and they do work pretty good for our older adults. As you can see, the tricyclic antidepressant can develop arrhythmias on our patients. It could cause orthostatic hypotension. So let's talk about how we're going to teach a little bit of this information to our older adults. The same thing we've been talking about is get the lowest effective dose that works for the patient. Another thing is for antidepressants, it could take several weeks for the medication to take effect. And so they may not be aware of that. So be sure you're teaching your patient about that. Watch the plasma level of the medication as well. And there are some side effects, which I've listed here. Sweating, blurred vision, there's lots and lots of side effects. Photosensitivity, fluctuating blood glucose levels. So your antidepressants have lots of side effects as well. Now, again, the dizziness, drowsiness, and confusion are important to remember with your antidepressants because they are going to be a fall risk. They can have mouth dryness because it's a side effect from these. So we can ask our patients to sugarless mints or ice chips, or sometimes, they can purchase saliva substitutes and put it in their mouth to keep their mouth moist so they can eat. If they become too dry in the mouth, they're going to not eat as much food, and of course, there goes their nutritional status. So we have to watch for that. Unfortunately, antidepressants can worsen depression. So observe for that. All the nice antidepressants really can cause depression, all right, or worsen the depression symptoms. It does the opposite of what it's supposed to do, but it can. And unfortunately, maybe some suicidal problems or thinking and behavior. So if you see any of these types of things, be sure you're notifying that healthcare provider about that. Find out from your patient. Okay. So which classification of the antidepressant medications have the most side effects in the older adult population, and ones that we really don't want to give?
D.
Yes. Very good. Yes. Tricyclic antidepressants, we kind of stay away from them if we can. Okay. Another group is your antipsychotics, and they're used to treat delirium and some other things, particularly for patients who have Alzheimer's or schizophrenia. They can help with the quality of life, but they do have profound side effects. Okay, I've given you some examples here. It's not important to know that it's a first generation or a second generation, but just know that you're familiar with these. Chlorpromazine, which is Thorazine, haloperidol is Haldol. All right. I know we've heard of Zyprexa, olanzapine. We see a lot of commercials on TV on that drug, and Abilify, aripiprazole, and of course risperidone, which is risperidol. So lots of antipsychotics our patients are on. Okay, the thing is about antipsychotics, they should only be used for treatment of the disorder, not for the managing behavior, right? And sometimes we think, oh, we need to give them an antipsychotic because of their behavior. Well, that's not the whole purpose of an antipsychotic. It really is to address the problem, not so much the behaviors of the patient. Another couple things that are important with antipsychotics, of course, is the anticholinergic effects. Everything becomes dry, constipation, urinary retention, obviously, blurred vision, a few other things, picking behavior where they kind of pick at stuff. All right, so that's an anticholinergic effects. And there is a great risk of developing these others, the extrapyramidal symptoms like tardive dyskinesia, dystonia. Tardive dyskinesia, just to remind you, is that it's an involuntary repetitive body movement. It could be grimacing, sticking out the tongue, smacking the lips, little rapid jerking movements, or slowly writhing, like little movements that, kind of slowly writhe, like a little snake. All right. So unfortunately, tardive dyskinesia does not typically reverse. Once the patient develops this on these antipsychotics, it's not going to go away. So it becomes a permanent part of them, unfortunately. So we have to, as soon as we see the problem, or we notice that the patient's been on an antipsychotic, then we need to immediately tell the healthcare provider, maybe they can give them something else, right, to try to prevent that from getting worse. Okay. They're going to have those, but maybe there's something else the doctors can give. They also can cause hypotension and make them sleepy, so they're also a risk for falls. And of course, constipation is also a chronic problem with them, a very common side effect. So is this true or false? Older adults are more sensitive to the extrapyramidal effects of antipsychotic drugs, tardive dyskinesia, Parkinsonians, akinesthesia, and dystonia. And of course, the answer is going to be true. Okay, absolutely. They're very, very sensitive to this, these effects on your antipsychotics. All right, almost to the end, class. I know you're probably ready for a break. Okay, so your sedatives and hypnotics, it'll chill them out a little bit. That's what they're used for. If insomnia, if they're restless at night, if they have some anxiety, of course, if they take them for too long period of time, then they become tolerant to it. So sometimes the dosage has to be increased. There's a few here. We should not give our patients diphenhydramine and chloral hydrate. There's some that we just don't want to give. All right. Melatonin, actually, your book does suggest using melatonin when you could purchase that over the counter as well. So how do we help them with insomnia? So let's try to do things without a medication. And here's some of the things I've underlined for you. The heat, the cold, if they can't sleep, noise, try to get them not to drink so much caffeine, do a little more exercise, make sure their pain is okay. You can do a back rub. All right. And of course, a lot of these things that as nursing actions that you can do, well, sometimes it helps instead of having to take another drug with all the side effects. And as you know, anybody taking sedatives are at high risk for falls. Do y'all see a common thread here in these medications? Many of our medications place our older patients at high risk for falls, which is bad because they're already at high risk for falls. And so always keep that in mind when you're taking care of these older patients. All right, and there's some interactions here. Okay. I won't ask you about the interactions, but just know that there are some interactions related to these sedatives. All right. Okay. So on a wrap up, categories, I think it's important that the categories of drugs and their major implications is very important. I did know at least one example for each category. I'll be clarifying that later on today in our exam review. Certainly aspirin, NSAIDs, digoxin, those are the common ones, all right, that are important. All right. And of course, think about if it's an anti-infective or antibiotic, what kind of nursing actions would I be able to implement for that patient in order to take care of them if they're on an antibiotic or if they're on a blood thinner or an anticoagulant, actually. Okay, so that was a lot of material in that chapter, but it's truly some review for you. I hope it helped a little bit for your farm tomorrow. It'll kind of refresh your memory on those huge categories of medications. So any questions about all of that before we take this nice break? Because I know you're ready. No questions? Okay. All right. When we come back, we're going to look at rehabilitative nursing. And some of these chapters are very short, so we should not have to rush so much. Okay. And then, of course, we'll talk about end-of-life care and death and dying for our older patients and look at a couple of short vignettes. All right, so it's 10:18. Oh, I've kept you a long time. Let's come back at 11:15. Okay, 10:18. 10:18. Yeah, quarter till. That'll give you about 15, 20 minutes to kind of stretch because you have been sitting for a long period of time. So I will see you when you return.